Nikhil Verma here with another edition of Things I Didn't Learn in Med School. Today's episode is going to be a little bit different than what I typically talk about. I'm going to do more of an educational conversation for patients, for anyone that's interested in back pain. Some regenerative medicine techniques can be relevant for any residents, fellows, medical students that might be interested in going to interventional spine or the musculoskeletal field. I want to start by talking a lot about my own back pain. And I've had on and off back pain since really high school. I had a pars stress reaction of my lumbar spine, which has progressed to really debilitating back pain for several years when I was younger. Especially this happened when I was about 15 or 16, and it forced me to quit sports for a couple of years. Really, all I could do was run in a straight line and lift. And I was really afraid to load the body with any significant mass or weight to really mitigate those symptoms. Now, to my own undoing, I didn't stretch a lot. I didn't do flexibility. I did what was told to me through some physical therapists, but I don't feel like I got the best value for what I ended up learning later on in life of how to lift correctly, how to hinge at the hips correctly, how to stretch correctly, and what proper rest meant for relaxing and resting the back muscles without just taking time off and laying on a couch at all times. So I just wanted to preface it with that because I think it's a very good conversation that we have as we're going to go forward into today's discussion. So forgive me a little bit. This is the first time I'm doing a conversation like this. So I kind of just Google searched a few things and pulled up a few slides, and I'll flip through them as I'm talking about everything. The thing I want to talk about is specifically these multifidi muscles in these erector spinae muscle groups. These are the muscle groups that are really responsible for stabilization of the lumbar spine and the sacrolumbar spine region. And you can even argue that it helps stabilize from the lower thoracic spine to the lumbar spine as well. As more and more evidence and data comes out, we're starting to realize the important role of the multifidi in particular, and how important it is to stabilize the lumbar spine and how it's a protective mechanism, but also helps further degeneration or potentially can prevent further degeneration of the lumbar spine. You'll see here, this is a picture of the spine as if someone were turned facing into the screen. So we have the multifidi muscle group here, where you can see they're attaching to the portion of the transverse process all the way up to the midline, and those are the spinous processes of the back, and those are what you can feel if you run your fingers down your back. And this, you can see it all attaches all the way down from the sacrum all the way up, and there's multiple levels of the multifidi. It really goes up and down your spine, but we really focus on this section here. And then the rector spinae group of muscles, they're a little bit more lateral, and they attach to different parts of the body, all the way from this fascial tissue all the way up through to the upper thoracic spine, rib cage, et cetera, et cetera. What I was correlating to was with my own back pain is when I learned how these muscles actually operated in doing things like proper hip hinging, which I don't have a great example of it right now. Maybe I can look one up. And we'll just take a quick video here, or image here. As you see this individual here, has a very nice flat back when he's hinging. He's pushing his hips back. He's keeping the knees at a very slight bend, not locked out. And that is a proper hip hinge in a forward position. And when you go up, your idea is to make a big arc back this way without necessarily losing that flatness of the back. Now, some people will exaggerate that flatness and get a C-shaped curve, which might not necessarily be the best thing, but that is also an example of a hip hinge. And you can see how important it is when we do lifts like deadlifts and keeping that back with a neutral spine, or what we call a neutral spine, I should say, and also very important for things like kettlebell swings. Now, I don't want to get too much into this. This is not trying to talk too much about how this function works, because I really do want to talk more about the functionality of the multifidi and the rectus spinae and what we're doing to treat this now. So that's a brief introduction, and we can see here. I kind of talked briefly how this spans the entire spine, but we really focus on the lumbosacral area for the most. So right now, this is a great article that was produced by Chris Centeno, who is a fantastic regenerative medicine leader in our field. He has written thousands and thousands of articles, blog posts, opinion pieces, or it seems like that many. I'm sure it's around there. He made hundreds of videos regarding regenerative medicine. Very respected individual in my eyes. We don't agree everything eye to eye, but there's a lot he talks about that I'm like, this makes a lot of sense. And a lot of things that he says, I reproduce to my own patients and explain to them, hey, you maybe want to go check out Chris Centeno's work on this. So right now, when we have low back pain that's not caused by a herniated disc or caused by any other dysfunction in the lumbar spine that we can treat surgically, we are forced to think about what other treatment options are there. And emerging evidence is showing that when these multifidi muscles in the low back begin to atrophy and begin to fibrose through different mechanisms of the body, it can correlate significantly with low back pain. Now, this is low back pain that doesn't radiate into the legs, no shooting pains, no sciatic pain typically. And we're starting to see that. Now, our treatment for a lot, quite frequently, when we have what we call this low back pain that doesn't shoot into the legs, is called axial low back pain. We look into what's called radiofrequency ablation. Now, the radiofrequency ablation targets the medial branches of the lumbar spine, and these medial branches are responsible mainly for innervation for pain signals of the facet joints in the lumbar spine. That's one of their main focuses. And if we go and radiofrequency ablate these or burn the nerves, then in theory and in practice, we actually see that there's a decrease in axial low back pain because we're burning the pain generators that would be responsible for those areas. Fantastic treatment for a certain subset of patients. And it works very well when it works very well. But one of the other functions of those medial branches is it does actually innervate those multifidus muscles in the low back and the multifidi muscle in the low back. And if we burn those, then you're also not getting the motor function of those back muscles, and that would lead to bigger atrophy and further weakening, which may potentially lead to worsening of back pain. So this article, you can see dated back in 22, we talk about, we have this ablative therapy of lumbar RFAs and the multifidi atrophy. So are we actually worsening back pain when we're doing these ablations? It's something to be said and something to think about intelligently, because if that is the case, then we should really be reserving this as a palliative last choice option for patients that don't have any other options, and we shouldn't be jumping to this very, very quickly in our algorithms. I have a medical student that rotates with me, and he and I were talking about this yesterday. And I was telling him are we actually doing more harm than good? And it's very important for me to kind of think about those things. And really give the best options for our patients. Not going to get too much more into this right now, unless something pops up. Yeah. So I encourage you to check out Chris Centeno's work on this on Regenx website and go more. So I want to show you a picture. These are MRI images, T2 weighted images, which essentially means that the fat and anything with high fluid content is going to show up white. And that's what we see here. These are axial cuts. So my mentor says, like, looking at rings of a tree. Here is the disc area. Here's the psoas muscle. Here's the group of multifidi muscles and the erector spinae, multifidi muscle, erector spinae. Here are the nerves. This is the spinal cord. Actually, the spinal cerebral fluid is the white, and the little dots are the nerve rootlets. The spinal cord is already ended above this. Here's the facet joint. Here's the nerves coming out, the ventral horn, the dorsal horn, ventral dorsal. Okay. So as we see of a normal multifidi muscle here, and this, sorry, I should say this is a BMC muscular disorders paper that was discussing multifidi fatty atrophy and lumbar disc degeneration. Before I move on to discussing this image, I want to say is that's what we're trying to figure out. Does back pain occur because this atrophy and fibrosis comes in first, or is it because the disc degenerates and causes that? Now, they found a low correlation in this study between the two, but as we're getting more and more data, I think we're going to understand more and more of what comes first, the chicken or the egg. And it doesn't really matter what comes first. And it may, when we're talking about regenerative medicine therapies or what we're doing to treat things, but it may not matter in the long run, because if you take my approach when we're doing regenerative medicine treatments for the lumbar spine, we're treating the entire functional spinal unit and all the structures in the spine and not just doing one spot. So we'll come back to that probably some other time. So as you can see, this white, again, is fatty infiltrate or fibrosis with the high fluid content that's coming in to the multifidi muscles. And that's mild. You see a much more increase of white, and you see a very severe increase of white here. So, because of this, we're trying to find better treatment options that we have available for patients in this realm. Now, because of this concept of low back pain, this company, Mainstay Medical, has actually come up with a device where we actually stimulate those muscles in the low back and actually reinnervate. And I won't want to say reinnervate because I don't know if we know that's necessarily what happens, but what it does to do is actually strengthen those low back muscles and allows you to have a reduction in low back pain. It's a fantastic procedure. Now, I should come to say that I have been trained in this procedure. I've done a handful of these procedures for my patients. I'm not a consultant or anything like that, so I don't have anything to disclose. I think it's a great technology. There are other companies out there in the peripheral nerve stimulation world that are using their leads off-label. That's another conversation for another day. But Mainstay is the one that has a on-label, FDA-approved procedure for this chronic axial low back pain that is correlated with multifidi atrophy. Now, a lot of people will say, "Oh, that's easy. If all this procedure does is strengthen the low back muscles, then why doesn't people just go and strengthen the low back muscles? Easy enough, right?" Well, it's a lot harder than it looks. Hinging properly is very difficult. Hinging properly with the proper amount of load is even more difficult. And some people actually do more damage when they are hinging with aberrant patterns or non-functional patterns when they're doing their bending forward and coming back up. We suggest that strengthening the muscles may help, but I think it's at best preventative from getting down to a bad path. But once the atrophy and fibrosis starts to happen, in my opinion, it's very difficult to reverse that without having a actual physical stimulation device to do such a thing. We put surface electrodes on patients and we tried to activate these muscles, and we saw that it was very difficult to activate the muscles to the degree that we wanted. And now I don't know if they've done studies for surface electrodes or EMG studies for using this actual device. We have seen people use EMG needles and record it, but these are all been like kind of experimental people playing around in their office with different ideas and techniques. What we don't know is how much this procedure can correlate with those activation of the muscles, but we do know they activate. Not only do patients verbally report to us that they feel the activation, but after the therapy has been going on for several months, which we expect it to take several months to improve, patients do have a significant increase of function and better increase or improvement of their back pain. And you can see their studies, the Restore study and the Reactivate B trial, where they did a sham control of neuromodulation, just nerves stimulation in this point. And you can see that there's a lot of really good data. Some of my colleagues are on these papers. I highly suggest if you have interest in this to look up this clinical information, because it really is exciting. And this is the coolest thing that I say is, as far as FDA is approved, this is the only restorative therapy that I know of in the realm of low back pain. Everything else we do, we either destroy nerves or we're using epidurals or steroid injections to ameliorate pain at best. But we're not necessarily restoring function. And this one, in my opinion, actually does restore the function. The last little bit I want to talk about is potentiation of how regenerative medicine protocols can help with the function of low back pain. So here's a study from 2019 that's talking about the influence of platelet-rich plasma and platelet-poor plasma on skeletal muscle repair and regeneration. Ultimately, they're showing that both the platelet-rich plasma and platelet-poor plasma have advantages for promising therapeutic perspectives. This was talked a lot about in a lot of the conferences I've gone to in the past several years in the regenerative medicine world, and it's more and more emerging data of how actually this platelet-poor plasma has advantages for muscles. And Dr. Bowers, Dr. Ram, Dr. Kenyon here, a few of my colleagues, very well versed in the regenerative medicine literature for platelet-poor plasma. And especially Dr. Bowers, who's giving a talk on this in a few weeks that I'm going to be very interested to attending. Talk about how platelet-poor plasma led to, I'll show you, myoblast induction and improve native muscle healing. So if we go back to our MRI slides and we have muscle that should look like this and might have transversed to this, if we can treat those multifidi muscle with platelet-poor plasma and potentially a little bit of platelet-rich plasma, are we going to be able to revert back into a healthier muscle tissue? Now, anecdotally, this is how I treat patients in my clinic when I'm doing a regenerative medicine protocol for their lumbar spine. I'm using the platelet-rich plasma for different things in the discs and plasma lysate for the epidural space, platelet-rich plasma for the facet joints, but I'm also making sure that I get down to the multifidi muscle and injecting that platelet-poor plasma in pretty copious amounts. We do get a lot of platelet-poor plasma when we're done with the spinning process, and we're injecting those into those muscles and those muscle groups and hoping for an induction of the myoblast production. And I'm hoping the PRP that's injected in the other areas would help the proliferation portion of it. So I think, quite often I'm having patients come to me saying, hey, I have this low back pain. I've been written off by so many doctors and they can't figure anything out. And we do these physical exam findings that are very specific for low back pain, axial low back pain that has failed things like epidurals and radio frequency ablations. And then we get the MRI and we see the multifidi atrophy. Then I have a long conversation of discussing, hey, these are the other treatment options. First off, I want you to try to see if we can mitigate this by properly activating the core, by doing proper hip hinging and what we call reverse hypers, both of which can be done very incorrectly um, and worsen symptoms. But with a trained professional, um, doing things like a reverse hyper can be actually very beneficial. I'm going to show this one because this is probably the safest way to do it. As you can see, this picture of the individual on their belly and their hips at 90 degrees, knees at 90 degrees, and they've kind of pushed their hips up, activating the glute muscles, but this also activates the multifidi muscles. Now, I don't really suggest patients do with the weight. I see people do this in the gym all the time, and all they're doing is using the momentum to throw their backs up there. I think you can get to that point with very, very good coaching, but for most people, body weight, high rep of body weight is very, very effective. And holding at that top position for 20 seconds, also very effective. Here's another example of hip hinging. You can see the back is flat in these situations. So that's the first thing I recommend to patients. That, hey, go through some videos, go through some proper physical therapy, and see if we can get this hip hinging pattern reestablished. If that's to no avail, then I have the longer conversation of, do we want to work in getting this device for you? Or do we want to talk about regenerative medicine, which is unfortunately not covered by insurance, but can be a very effective treatment option for you in your lumbar spine? Um, and then we also, after this, is I continue to tell them, if we do a regenerative medicine protocol, we can always still come back and do the mainstay reactivate procedure. But if we do the mainstay reactivate procedure, I'm not certain how effective coming back into a regenerative medicine protocol would be. Now, you may not need it because the reactivate procedure does its job, but it could be um, a way to see if your body's going to respond to the reactivate procedure. And also, I don't want to necessarily have to put a device in someone if we can get away with a non-invasive, or sorry, minimally invasive procedure that can be done in the office under an hour. So, all right. Well, I hope you guys found this useful. If you have questions, feel free to send me a direct message, drop some comments in the comment section, send me an email. And if you're a patient and this seems like a conversation that, hey, I really want to learn more about this, try to set up an appointment with us. Central Sports and Spine Columbus, or Central Sports and Spine Solutions in Columbus, Ohio. Click on the links below and you'll find our contact information. And talk to you guys soon. Thanks.